Good morning, my name is Israel Villarreal. Welcome to my clinical case in this section of interesting cases. My case is about a 29 years old female patient who came with ultrasound to come with us, to present a laboratory result with parathyroid hormone rather than 1000. A parathyroid tumor is suspected in this patient, so the study of choice is ultrasound. We perform a ultrasound of the neck where they are identified in the sagittal section of both thyroid lobes. Two images per side, which are projected extrathyroid, posterior to the thyroid gland. Each one of these images are identified as oval with defined edges, hypoechoic in comparison with the thyroid parenchyma. Some of them with small areas of colloid degeneration inside. We characteristically identify increase in color Doppler flow with a neutron vessel in its parenchyma. With these findings in ultrasound, we are guided towards pathology of the parathyroid glands, characteristic parathyroid adenoma. As within the thyroid, an understanding of the embryological development of the parathyroid glands facilitates localization of some of the normal anatomical variants affecting these glands. The inferior parathyroid glands develop from the dorsal aspect of the thyroid, of the third pharyngeal pouch, with the thymus developing from its ventral aspect. The thymus migrates caudally and medially, pulling these parathyroid glands with it. They then lose their connection with the thymus, usually stopping at the dorsal surface of the lower pole of the thyroid gland outside its fibrous capsule. And the superior parathyroid glands develop from the fourth pharyngeal pouch, attaching themselves to the thyroid as it migrates caudally. Their position is usually more constant and predictable than the inferior parathyroid glands due to the shorter migration path. They usually lies in the dorsal surface of the thyroid, also outside its fibrous capsule, but more posterior and medial than the inferior. Almost invariably, the indication for imaging parathyroid glands is to localize one or more glands causing hyperparathyroidism and therefore hypercalcemia. The features of parathyroid adenomas on ultrasounds include elliptical, hypoechoic solid nodule, and this can appear at end when retrothyroid due to facial plans, but often appear more round if are intrathyroid. Cystic components are relatively common, ranging for multiple small areas, and calcification in these lesions are rare. 90% of the show an hypervascular intraparenchymal prominent artery pattern. The location of these glands might be the following. The superior glands location, the most common is the cricothyroid junction, intimately associated with the recurrent laryngeal nerve. The dorsum of the upper pole of the thyroid in 22% of the cases, lying deep to the chirurgical capsule of the thyroid, and retropharyngeal or retroesophageal location, which are rare. But in this location, the realization of maneuvers help the visualization of the adenomas and be performed by moving the trachea towards the sides to see the protrusions of some suspicious images in this area. And the location of the inferior parathyroid glands The most common is as the lower pole of the thyroid in 42% of the cases, either at the anterior or posterolateral surface of the lower pole of the thyroid. And within the thymic tongue, a distinctive anatomical structure which extend from the lower thyroid pole to the mediastinal thymus. And juxtathyroidal, it's a location, a variable distance lateral to the mediastinal thymus, lateral to the lower pole of the thyroid, and ectopic localization in 4% of the cases within the mediastinal thymus, typically 3 to 4 centimeters below sternal notch. Recommendation for patients who we see these lessons is hyperextension of the patient next. Is exceptional for optimal parotid evaluation, and high-frequency transducer provide optimal assessment. Scanning whilst swallowing can also help to visualize low-lying inferior glands by evaluation of thyroid and associated structures. And the majority of abnormal glands demonstrated will be hypoechoic and hypervascular on Doppler ultrasound. And polar feeding vessels is also a typical and useful observation. These are seen at the caudal part of the inferior parathyroid and cephalad part of the superior glands. And as a parathyroid ultrasound usually performed as a preparative localization technique, and surgeons often find static ultrasound images difficult to understand. Meticulous reporting with reference to constant anatomical structures is very important for the surgeon to perform the surgery. And that's it. Thanks for the attention.
Good morning. We're going to continue with interesting cases. My case is about, well, I am Ulises Longoria Estrada, and my case is about a 62-year-old male who presented to this hospital. It was in November of the last year, with abdominal increase of volume and referred no pain, well, referred mild chronic pain, but no fever, no other clinical symptom. He had no important medical history except for a surgery that was a cholecystectomy that was performed 10 years ago, and he said it was for lithiasis. He was referred to this department from the family medicine consultation with a suspected diagnosis of chronic hepatopathy. So we performed an upper abdomen ultrasound where we found that the liver was was increased in volume, was mildly increased in echogenicity, but the margins of the liver were smooth and there was no other sign of hepatopathy. So the liver had no focal lesions, just these findings consistent with mild steatosis. In the topography of the gallbladder, we found this image that is a multiloculated cystic mass that had internal septa, and all the material that we found inside this mass was predominantly anechoic, but some internal echoes were present. We tried to see the boundaries of this image, but by this ultrasound, the boundaries cannot be couldn't be well seen. we saw that the common bile duct was not dilated. And in the right hypochondrium, we saw the same image. And in the here is the same, but just in a sagittal view. And also in the hepatorenal, in the Morrison pouch, we found that the same image was even extending to the Morrison pouch to the ipsilateral iliac fossa. So we suggested this patient an abdominal CT scan that was performed a week later. And in this abdominal CT scan, we have here the correspondent scout. And we found, we can see that indeed the abdomen is distended, and we can see that it's very, we can see the opacity of the abdomen predominantly in the right side of it. So we have here some slides of the study, and we can see this that is consistent with the findings that we had already seen in the upper abdomen ultrasound, which is a cystic mass that we are more, if we study this more recursively, we can see that it has some internal septa, very thin internal septa that we could see better in the ultrasound. So we are in the context of cystic multiloculated mass that we found in the abdomen, and is mainly in the right abdomen, but we can't see that this mass arises from any of the abdominal structures. So this is not a tumor that arises from the liver, nor the kidney, nor the pancreas. And we see that is not conditioning the collapse of any of the vascular structures either. So we can establish top differential diagnosis between many pathologies, and I just write down here 5 most common multicystic intraabdominal masses that we can evaluate in a patient that can present with these features in the CT. So we are going to review briefly pseudomyxoma peritoniae, organizing hematoma, peritoneal inclusion cyst, complicated ascites, and lymphocele. Pseudomyxoma peritoniae is an accumulation of mucinous implants due to rupture of appendiceal mucinous neoplasm. This mass, this pseudomyxoma, is slowly progressive, and the symptoms could be the same as the symptoms we saw in the patient: the abdominal distension, the abdominal pain, and the weight loss. The demographics, we can see that is most common in female rather than male. And this pseudomyxoma is a multiloculated cystic mass that we can find that the main or the dominant cystic or solid mass could be found in the right lower quadrant, that is the expected location of the appendix. And some implants may show curvilinear calcification, as we can see here in this CT scan. These cystic masses can provoke the central displacement of the bowel loops, and in the ultrasound, despite its cystic mass, we can see some solid appearance or echogenic foci inside these images. Another differential diagnosis is an organizing hematoma. Nevertheless, the patient didn't have a history of trauma, and nor coagulopathy, or wasn't either in anticoagulant therapy. And the patient had normal laboratory values, so we didn't suspect bleeding in this patient, nor present nor chronic. And the imaging features is a localized collection with multiple septa, thick septa, horizontally aligned with or without layering debris. And in this patient, even though we saw some echogenic foci inside the mass, we didn't see actually debris in the ultrasound nor in the CT scan. A peritoneal inclusion cyst is a pathology that is most commonly found in women. It's almost exclusively found in premenopausal women. And this peritoneal inclusion cyst, or pseudocyst, is just ovarian fluid trapped by peritoneal adhesions. And this could be a palpable mass causing pelvic pain and abdominal distension, and tends to recur after the drainage. This peritoneal inclusion cyst we can find in the pelvic ultrasound a normal ovary surrounded or displaced by fluid containing also septations, and it arises from the anexa that could be unilateral in 65% of the cases or bilateral in the rest of them. Here, the thing is that the peritoneal inclusion cyst can be deformable and lacks of mass effect over other solid viscous. Other differential diagnosis is a complicated ascites, that is an abnormal accumulation of fluid within the peritoneal cavity. And we can see too the echogenic fluid with septa and coarse or fine internal echoes. The clinical issues, of course, is always associated with a chronic hepatic disease or a peritoneal mass with double S. And clinical issues can also include a fever, leukocytosis, and abdominal pain, also with abdominal discomfort and distension. So what we can see here in this mass is the same multilocular cyst. Nevertheless, the density is increased, and we are not seeing the typical density of the water, but is increased. That is suggesting us the internal debris and the internal. There are some signs of the complication of the ascites. Here in the ultrasound, we see that this is not fully anechoic, all this liquid that is surrounding the liver, and we see indeed a very small liver with heterogeneous echogenicity, and the gallbladder has a reactive thickening of its wall. Another differential diagnosis is a lymphocyl that is more rare than the rest of the cases that I had presented. But this lymphocyl is the post-surgical complication that develops when the lymphatic system gets damaged during a surgery. More especially a surgery involving a kidney transplantation or urological or pelvic surgery, but it can also be a consequence of instrumentation of the lumbar of thoracic spine, because some important vessels of the lymphatic system are near these structures, like for example the cisterna chyli, and most commonly is associated with extensive procedures, and is usually found in the retroperitoneal space. The lymphocyl also causes the same symptoms that we have already described in the last cases, with growing the size of the abdomen and some symptoms that depends on the compression of the structures. And the treatment for this pathology is the drainage under CT or ultrasound guidance. And by draining this fluid, the patient will immediately feel the relief of the symptoms. So we do not have a histological, or we do not have any other study for this with this case in this patient, but we reviewed this case with our professor of ultrasound, and he suggested that the most appropriate diagnosis for this patient was this last differential diagnosis, which is the lymphocyl. And according to the history of surgeries in the patient, well, he had only underwent cholecystectomy, but is the diagnosis that we finally left in the report in this case. That's it. Thank you.